Okay, wonderful. Welcome. Greetings, everyone. We'll just give a few minutes for people to join. And welcome to our speaker, Dr. Kudua. I wonder if you'd like to just check your slides in this space.
Okay.
Thank you. Kim, I've asked Joy to go into the parallels into the UHC one and refer people here. So she'll share the link.
Okay, thanks.
Just checking if, do you have any issues to share slides, Augustina?
Trying to share the slides now. It's not opening. Okay. Almost there.
Ah, we can see your slides. This is wonderful. Thank you.
Okay, great.
Thank you. Great. And we'll
Can you still see me? Can you see me?
This is the strangest thing. We cannot see you, and I'll check mine.
Okay. So let me put the camera off then.
Okay. Apparently, you can see how windy it is in Cape Town from my blinds.
Yeah, I wanted you to see Ghana.
I know. I wanted to see Ghana. But what a pleasure that we can have these meetings and we can join together from all these distant corners. I'm so grateful for that. So let's give a couple more minutes. It's 3 o'clock on the dot. And yes, I see there's a different functionality in this new one. Simon, yes. Make a presenter. Yes. Simon, I hope you now have full functionality.
It looks like it. Can you hear me?
Yes.
Great.
Yes.
Great. See, people are still making their way in. Very welcome, everyone. So Simon, I wonder if I should just orientate to this webinar series, and then I'll hand over to you for the important task of introducing our special guest. Colleagues, my name's Tamara Credo. I'm based at the Health Systems Research Unit at the South African Medical Research Council. And where Kim and I, Kim Jonas, who's on the line, have been co-hosting a regular webinar series. It's been a little bit patchy of late, but it's one that we try to host regularly that kind of brings a spotlight to UHC issues in light of the kind of the legal changes that are happening in South Africa, but also our general interest in how we strengthen health system services and policy research. So this is a regular webinar. It's an open discussion forum. We have wonderful guests, as you'll hear, we have today. And the idea is to share ideas, experiences, opportunities, collaboration ideas across all of us. So I really welcome everyone, as you're listening, to think about your own experiences and then bring that into the discussion afterwards. But I will now hand over to Simon. Thanks very much and enjoy. Bye.
Thanks, Tamara, and I'd like to add my welcome to everybody online. I'm Simon Learn, also based in the Health Systems Research Unit at the South African Medical Research Council and the Norwegian University of Science and Technology. And it's a real pleasure to welcome Augustina Kodua to the series today. Augustina is a senior lecturer in health policy and systems and pharmacy practice at the University of Ghana, where she also heads the Department of Pharmacy Practice and Clinical Pharmacy. And I've known of Augustina's work for many years, both in pharmacy policy, but also in health systems research more generally. And I've had the pleasure of working with her on a research project for the last maybe 3 or so years, Augustina. So very much looking forward to hearing about your topic today. And without further ado, I'll hand over to you. I think, if I understand correctly, you'll be talking for about 25 minutes, and then I will have plenty of time for questions. Over to you.
Yes. Okay, so thank you so much, Simon and Tamara, for the introduction. And good afternoon to everyone. So my name is Augustina Kodua, and for today we'll be discussing policy making processes, and we'll be putting a lot of emphasis on power, how policy actors are able to exercise their power in policy making processes in the health system. So by way of outline, we'll briefly look at what is public policy, and then policy within the health system. We'll look at the policy-making processes, how actors influence, who they are, and how they use power to influence the policy. Then we will look at 5 case studies. So those are research work being done, health policy analysis done, drawing on power, contestation, and politics. So we'll broadly be introduced to these 5 case studies. And then during the discussion, we can go in depth if there are questions on them. And then we'll have take-home messages. And hopefully there'll be enough time for a lot of discussion. Okay. So when we say policy, policy is whatever we decide we want to do. So public policy is whatever government chooses to do or not to do. If we bring this to our households, at home, what you decide to do in your household, in a way, is your policy. Okay? So that's a broad way to understand policy. In public policy, the policies are being authorized or formulated by individuals or institutions with the mandate to make these policies. So maybe the parliament, the courts will come up with an act or a law. Government officials will come up with specific guidelines, standard operating systems. These are all policies, and they tend to create some public value. Okay. Now, when we zoom down to the health system, where we are looking in depth into service delivery, health systems financing, we are looking at medicines, vaccines. Here, policies are the broad statement of goals and objectives. So the plans that we have in providing service delivery, plans and objectives, goals in providing health systems financing, universal health coverage. So broadly, this will be the policies within the health systems. Okay, so it means that we can conceptualize policy as intent, our visions, our goals, understanding, or practice, the way we do things, our routine decision-making processes, our understanding of how things should be done, again, as policy. So policy is not only presented in documents or laws or a minister giving a statement or the president going somewhere and saying from henceforth, every pregnant woman will have lunch when you go for antenatal. And it's documented, but also policies are constructed in what we do. If we go into health facilities in South Africa now, depending on the level, whether it is, let's say, teaching hospital or national, the way patients are received to go into consultation or meet a doctor, the processes will be a bit different, but may not necessarily be written anywhere. So if you enter the hospital, the way you are directed to go and see a doctor, and then from seeing the caregiver, you move into the dispensary, may be different from another hospital. So that is their policy in that facility. It is constructed, is not necessarily documented, but it's policy. So this arrangement that happens in practice can be studied. So you can do a policy analysis on that. Okay. Now, when we talk broadly about policy, it's of interest to understand what is happening within the policy system. We want to know how the policy actors are able to formulate, whether it is documented or in practice. Okay. So the policy process is quite complex. We can imagine that before a document comes up, many individuals would have met, discussed, proposed problems, discussed, and then put it on the agenda before it is documented and implemented. This will certainly involve a lot of contestation, resistance, and negotiation. And it's because we generally do not want to change. And so when there's a policy change, you may have resistance. Now, to understand this complex process, there are several frameworks or concepts that helps us to unpack the complex policymaking processes, the different actors involved, what is it that they do. One of the ways is looking at the policy cycle with this simple stage model, where we are conceptualizing the complex process as a clearly movement from agenda setting to policy formulation to implementation and evaluation. Okay, so ideally we are saying that we will move and come back to the agenda setting process. Now with agenda setting, we are the policy actors. This is where they try to identify problems. What is of importance? What is it that we should focus on, pay attention to? So the issue problem definition is very important in policymaking process. So in this way, it means that this is the first thing we look at, identifying what the problem is and deciding that this is something that we will want to look at. So if it is government, this is something government wants to pay attention to. If it's within the health system at a facility level, this is what at the facility level they want to pay attention to. So for example, service delivery, or example, information systems. Do we have to come up with some patient charter, things that we need to do? So this is very important point in the policy making process. After that, we move on to the formulation. So we know what the problem is. We have some proposed solutions. This is where we put details, content, meat to the agenda issue. So the strategies, what is it that we plan to do? So we formulate the policy. We have the text. So if the policy is documented, this is where we do the documentation. Okay. Then we implement. So this model is saying we move from agenda setting, formulation, then we implement. We put it into practice. We implement the goals, aspirations, the plans. Okay. Then we come back to assess whether the policy that we defined, the problem we had, the solutions, and we have implemented, is it successful or not? So in a way, the model is saying that we go back to assess the policy and then come back to the drawing board. So the drawing board is coming back onto the agenda to see whether we can modify something, change, or indeed go on and implementing the policy. Okay. So in research, this is a very useful model that helps us to unpack the policy, complex policy process. In practice, agenda setting may not necessarily move neatly into formulation and into implementation and evaluation. Sometimes the agenda is set, an issue is defined as of importance to governments, and then it goes straight into implementation, meaning that we may not have clearly defined plans or policy formulated as to how this should be implemented, but we go ahead and implement. Sometimes policies are implemented, we may not necessarily evaluate to see whether it's successful, to inform the next stage, and we may go on to even revise without actually evaluating. So in real life, the policy-making process is quite complex, but this is a useful tool to help us understand the different components within the policy-making process. Now, when we think about policy-making, we are definitely thinking about the policy actors because they will make the policy. So the policy actors include government, institutions, individuals, groups. But for them to formulate and implement policies, it means that they should have some power, authority to act, to make the policies, for example, or they should have the capacity and the expertise to implement the policies. So if they are into service delivery, they have the expertise as medical doctor to provide service. Okay. So it means that within the policy making processes, power is very important. And the policy actors have different sources of power, which we'll discuss later, and they use this to influence the processes. Okay. As I mentioned earlier on, when we go back to the stage models, it's when you move from agenda setting. Problem definition is very important. And it's because within the health system, we don't have just one problem definition. Okay, so if we take a typical example of access to medicines, access itself is a broad term. Is it geographical access to medicines? Is it financial access to medicines? So if we want to formulate a policy around access to medicines, are we going to ensure that the medicines are available at the facility at any cost? Or we want it available at the facility at a cost that we can afford? Okay. So the one who is able to define what the problem is and get others to think alike is quite a powerful person when it comes to policy making processes. Okay. Because this is what feeds into the agenda setting processes. Okay. So to make decisions, to implement decisions, policy actors, whether they are setting the agenda, whether they are formulating, whether they are implementing, evaluating, will need some source of power. The source of power, we will look at the different types, is not just enough, but with the power, you should be willing to use it. And I always use this example. So let's take it that you are the Minister of Health in South Africa. Then you go on holidays. Well, you come on holidays to Ghana, and you're on holidays, and there's a discussions around policy making at national level. You are invited to a meeting. You are in your capacity then as a tourist. You are very powerful in South Africa, but in Ghana on holiday, not you are just looking onto the meeting. Your contributions and things that you say may not necessarily carry weight because of the context. Okay, you may be willing to use it, but you're unable to convince us because within our context, you are not very powerful. So context, the use and exercise of power is important as we think about the context. So everyone is powerful in relation to someone, in relation to something, and within context. Okay. So Mensik is proposing 5 main sources of power. So the control of a resource, technical skills, a body of knowledge, by virtue of one's position. So you are the director for health services. That makes you very powerful. You have privileges to impose choices and make decisions. Okay. There's a fifth source of power, which is quite dominant. I mean, within our setting, it's being used a lot. And those are individuals who have access to the other 4 of power sources that we've discussed. So they have access to people who have control over resource, or have technical skills, or have body of knowledge, or have positions. Okay. So they are able to use their access to others who are powerful to influence decision making. And when we move into the case studies, I'll give you some examples of how people are able to draw on the fifth source of power to influence decision making when it comes to policy. Okay. So to understand policy processes, it's very important to try to unpack the complex processes of agenda setting, policy formulation, implementation, and evaluation. But 2 main things stand out. So one is to understand the characteristics of these policy actors. Who are they? What powers do they hold? And how are they able to control each other, influence each other, and influence the process? Okay. Are they policy agenda influencers? Are they defining what should be the problem? So it's universal healthcare. We can look at universal healthcare in several ways. Are we going to target access to medicines or service delivery or NCDs? So the agenda influencers are people who are going to help us define what the problem is. So what power do they bring? What power sources do they have? And how are they able to do that? The other important thing to consider is the venue or the domain in which these decisions are made. So within bureaucratic circles, so let's say in the ministries or in the regional health directorates or the province directorates, at that level, decisions are made within, let's say, a closed venue. The people who work there with the mandate are able to make these decisions, okay? Sometimes things that happen in the public domain. So on the news, something happens, it has bearings. So decisions are also made within the public space. So we are looking at the characteristics of the actors, the power they have, how they are able to influence each other in the process, the venue in which decisions are being made. And again, this will be clear when we look at the specific case studies. Okay, so I have 5 case studies that I want to share. So I'll give a brief overview. The papers are open access, and we can read and also discuss during the discussion section. So the first one is technical analysis, contestation, and politics and policy agenda setting and implementation. Here, we are looking at the rise and fall of primary care maternal services from Ghana's capitation policy. So during the agenda setting processes, it's been identified nationally that our national health insurance implementation it's suffering in a way because our expenditure is way higher than our income. So if we don't find ways to balance this, very soon our health insurance will not be very effective. So based on this, a committee was set up with people with technical expertise to formulate a policy, capitation policy, as a way of paying the providers. Okay. Now, the idea was that they want to use capitation for OPD, so outpatient section. That's the only place that capitation will be used. Decisions were made. Individuals with expertise were involved within the bureaucratic arena, meaning that different stakeholders were invited, but the decisions and the processes occurred within the ministry, the Ghana Health Service, and also with the National Health Insurance Authority. So the policy has been formulated. Now, during implementation, the committee that was formed to formulate the policy involved service delivery individuals, okay? Their representatives were part of it, formulating the policy. But during implementation, they were able to resist the implementation. And they had reasons to say, well, the capitation rate was very low. Maternal health service is a given outcome. So in capitation, the idea is to share the risk between the insurer and the caregiver. Okay. But in pregnancy, when you are pregnant, you definitely will go to the hospital. So the outcome is given. So for them, it should not be part of capitation. The rate is so small. And during their interactions with their clients, the patients, they were able to convince them that this policy that government is implementing is not in the favor of the patient. And the patient is at a disadvantage. So they also drew on their social power, street level bureaucratic power to revise and influence a heated debate within the public arena. So this policy was being discussed on radio stations. And in an election year, government had to do something. Okay. So government authorized the Minister of Health to revise the policy. So maternal services was removed, the capitated rate was increased. Okay. So this is an example of how different policy actors can be part of the process and influence decisions along the cycle that we have just looked at. Okay. Now, with the second case here, we are saying that the one with the purse makes policy. So clearly, it means that the one who has money is able to define what the problem is, frame issues or frame solutions for implementation. Okay. So an example here again, we are looking at how at national level, different actors, including technical experts from the ministry, Ghana Health Service, and also our donor partners. Our donor partners are involved at high level decision making when it comes to policy design in Ghana. And they were able to use their control over and access to resources, mainly financial resources, to direct in a way how policies should go when it comes to maternal health. Okay, so the power sources that were really clear in this example was legal and structural authority. So the ministry had processes that allows for decision makings to select or prioritize issues for the health system. Okay, now because stakeholders are involved in this processes, it means that during decision making, they have inputs, and based on their power sources, they are able to direct issues in a specific direction. And here, the money was doing the talking. Okay. So that's another example of how the availability of resources can direct what policy is being implemented. In the third example, we are looking at the use of evidence and negotiation in the National Standard Treatment Guidelines and Essential Medicines List. We know that the Essential Medicines List and the STG is generated from using evidence. So this is where treatments for specific disease conditions, you want to look at randomized control trial, you want to look at some systematic reviews being done, health technology assessment. So it's purely based on the use of evidence and then expert opinion. So the design, the processes will start with a committee. So there's a selection committee inaugurated by the minister. So they have the authority to revise the standard treatment guidelines. Okay? They have the expertise. So that's their source of power. Now, when the policy is formulated, to ensure that there's use within the system is usually subjected to stakeholder engagement. And at one of these stakeholder engagement, which is within the public arena, we had other healthcare managers and professional bodies and service providers looking deeply into the medicines listed and the level of care. So within our settings, we have different levels of care where different practitioners can provide services. So for example, at the community level, you may have a community nurse, and some medicines may not be available to them because within the guidelines, they are unable to diagnose and prescribe certain medications. Okay. Now, when this STG was in the public domain, there were a lot of discussions and negotiations. We had one, and this was the first time. I've been involved in the review severally, and this was the first time an interest group, a professional body, went straight to the Minister of Health to register their displeasure with some medicines that were not listed to their level. Okay, so they are using the fifth source of power, their access to the Minister of Health. So instead of coming straight to the formulators, they went straight to our bosses to inform them that, oh, well, they are the community level, they are in the rural areas, and these medicines for hypertension and diabetes, they should be able to prescribe and dispense. So we based on this practicality, we had to renegotiate and bring some of these medicines to a lower level. So they used their sources of power. They were willing to participate in the policy-making process to make a change in their interest. Okay. Now, the fourth one is looking at medicine pricing policies in Ghana. There's another interesting work that also involved the use of access to policymakers. We have a group in Ghana called the Chamber of Pharmacy. They are more like an NGO, and they have interest in pharmaceutical systems. So they proposed, just before the government came to power, they proposed to the government that if government exempts the payment of VAT, a value-added tax on some imported medicines, they will guarantee a 30% reduction in medicine prices on the National Health Insurance List. Okay. So again, government agreed, and the ministry, together with other stakeholders, formulated the policy of that exemption, and then ring fencing specific medicines only for local manufacturing. Okay, so they were all involved. So within the ministry, the non-health or non-government stakeholders were highly engaged and involved, okay, to co-produce this policy. And the idea was that we wanted them to be able to implement from the beginning. So their inputs, views, and opinions were included in the policy-making process. Okay. Now, their involvement reflected their expertise. So the actors either were pharmacists, were importers, wholesalers, representing the pharmaceutical society, local manufacturers. They were highly involved and influenced decisions and the content and implementation of the policy. Again, it's good to understand who they are, their power sources, and how they are able to influence decisions. Then the final case I want us to look at is policies that are formulated within parliaments. Okay. So this is on a clear existing law. Now, this law seeks to regulate pharmacy practice. So that is the profession and then the premises. Now, over the years, decades, we've had the Pharmaceutical Society in Ghana since 1935. So way back, the Pharmacy Council has always regulated pharmacy premises and the profession. Okay. So in 2010, the ministry with its stakeholders constantly reviews laws. So a new bill was drafted for Pharmacy Council, and another one drafted to regulate health facilities. Okay, so we had two separate bills. Now, the one regulating the health facilities went on to Parliament. It was passed into law. Now, during that period, that law bill, in the bill, there was no mention of pharmacy because there's already an existing law that regulates premises. Okay. So the committee has met severally. This bill was presented to the Parliament's Select Committee on Health, and usually they will invite stakeholders to come and make inputs if there are changes. All this was done. And then the bill was discussed on the floor of Parliament. Now, on the floor of Parliament, only parliamentarians can make inputs. They can discuss the bill and make changes. Now, on the floor, a parliamentarian raised the issue that pharmacies are health facilities. And with that just basic framing of pharmacies as health facilities, then it means that pharmacies should be regulated by the new agency that is regulating health facilities. Now, even though this is not the norm, on the floor of Parliament, the Pharmacy Council couldn't make any change. They are not parliamentarians. The society, even the ministry, the director for pharmacy, they were all unable to participate in the processes because of the legislative procedure and the venue in which the decision was made. They were unable to influence the decision-making processes. So in the end, an act was passed, and this act ensured that the Pharmacy Council only is to regulate the profession. Okay. Now, of course, when it was implemented, it's not part here, but in practice, now that it's being implemented, the Pharmacy Council is still regulating both profession and premises. So an example of how policy actors are able to change policies based on the venue and the arena in which decisions are made. And then policy implementers' ability to revise, become street-level bureaucrats and change implementation of a policy to implement it the way they see fit. Okay. Again, we can discuss in depth any of these empirical evidence that I have shown. So just to wrap up for our discussion, it's important that to influence policy or to even study policy process, we have to think about power. There are several ways to conceptualize power. Okay. But we want to know who these actors are, what power do they have, and how are they able to influence each other and influence the process. Who are the people with the authority to act? And where are they doing this? How are they able to influence decisions in deciding what is the problem, in setting the agenda, because this is an excellent way to exercise power. Okay. The venue, where do we take these decisions? Is it during sideline meetings? Because during sideline meetings, decisions are also made. Is it on the floor of Parliament? There are some laws that are made on the floor of Parliament. There are some decisions that are made at the back doors. It will be interesting to try to unpack how policy actors are influencing the processes and how they are able to do that, and who is invited to the meeting and who is not. How are they able to make change when they are there or not? These are all important questions that I think we'll seek to explore as we move forward to understand power within policymaking process. At this point, I will stop, and if there are questions, comments, then we can discuss. Thank you so much for your attention.
Thanks so much, Augustina. That was really fascinating and really helpful, interesting overview of these processes. So, yes, as Augustina said, we're open to questions. I think you should be able to put your questions in the chat, but I think you could also raise your hand, and Tamara will probably be able to unmute you if you can't unmute yourself. I'm not sure if you'll be able to unmute yourself. So would anyone like to raise a question? Oh, someone's asking if a copy of the slides will be available. I believe the seminar is being recorded, and maybe Tamara, you wanted to say where that recording will be available.
Yeah, that's a good question. Yeah, we are recording and we'll circulate it to everyone who registered. So there's some people who couldn't make it in the end, so we'll circulate that link.
Super, thanks. Any questions from those in the room? While you're thinking about that, Augustina, I perhaps could come in with a question. I was wondering in the work that you did for these case studies, if you also looked at the influence or power that researchers were able to wield in these processes, if any, either through provision of evidence or information or in other ways, and also the roles of civil society actors. I was wondering if you could say a bit about that.
Okay. So thank you so much, Simon, for the question. Yes, so the power of researchers, it happens a lot. So for example, it really would depend on how the research is being done. So if I use my example, I used to work in the Ministry of Health. And when I started my research, my data collection was also within the ministry. Okay. Now, when I started with data collection, now they knew me as a researcher. So sometimes when I go for meetings, they'll ask me whether I'm here. So we have this guy we call Anas. He's been doing investigative journalism. He doesn't tell people things, and he records. So they'll ask me, are you Anas? Then I'll say no. So I have to explain what my research is about and all. So over time, beginning, they were a bit hesitant because I had to shadow people and listen as part of collecting my qualitative data. So they were not a bit open. That after weeks open, now I was taking notes for them. So when I go for meetings, I take notes for the meeting as part of taking notes and using it for my research. In a way, as a researcher, then you are also able to frame things because I was taking the notes. I'm able to frame, not influence decision fully, but in a way affect how they think about things because I'm the one recording. So it depends on the role that the researcher plays in the decision-making processes as part of your research. Researchers can also present findings. You know, we are always pushing for getting research into practice. To get research into practice means that you should involve the policymakers from the beginning. So in conceptualizing your research work, so they are part with the co-production. So that's a way. With the role of civil society, yes, they do play a role. Again, to use Ghana as an example, we have what we call the Coalition of NGO in Health. And they are involved in high-level decision-making processes. Now, the question will be, what evidence or what power, how do they, when they are there, do they make any influence? Because you can be there and say nothing. You are just representing, warming the bench. So it will be interesting to know, when you are there, what impact are you making? This is something that we'll have to investigate and probe further. But indeed, yes, the civil society have a role, the use of evidence, their participation in decision-making processes. Over.
Thanks, Augustina. I see we have two linked questions which sort of touch on something you said a couple of minutes ago. So the one is from Fatuma, who says, if you're not embedded in the system, how do you get an idea about these sideline meetings that you mentioned, where decisions are made and who is making them? And then following from that, Ida noted, how do we research such sideline policy decisions if you're not embedded in the process, I guess, as a researcher?
Very interesting questions. And so there are several research methods. We have ethnography. You usually in policy analysis, you have to find a way to embed yourself within the system, whatever it is that you are studying. This is where you have in-depth understanding. Okay, so you can do a policy analysis and look at documents, not really interview anyone. You can also do the same analysis, documents plus interview, and embedding yourself in the situation. As I mentioned, when you start data collection, when you go initially, there will be some form of resistance because they are not sure what is it that you are doing, what you are collecting, are you going to report them? But very soon, when they realize that, oh, yeah, harmless, yeah, researcher, trying to document what is it they are doing, they open up. They will actually tell you the sideline decisions. They will tell you the discussions behind the scene. Do you know that we talked about this even before we had this meeting today? And it's because you are within the system, you have interviewed them severally. So you have that relationship with them. They trust you to give you information. So you need to embed yourself. If it's not possible, again, you can do document review. You can do a scoping review. You can do a document review of a system policy and try to explain. But to have power analysis in depth, you will need to, in a way, embed yourself within the system. Thank you.
Thanks, Augustine. So I see we have a couple of further questions. One was from Andiswa, but this is a very broad question, so others may also want to come in here. I'm a student pursuing public health studies and have an interest in the development of the national health insurance model in South Africa. What are the main skills required for one to be involved in such policies? So I'm not sure, Andisa, if you meant what skills are required if you're involved, for example, within a department or Ministry of Health, or what skills are required to research such policies. Maybe you could clarify that before Augustina answers that question. So maybe if you could clarify that in the chat. And then we have a follow-up question. Actually, Tamara, did you have your hand up a moment ago? Did you want to come with a question?
I do, but I think these others are so interesting. I'll come in if there's time. Thanks.
Great. So Fatuma asks, in the case studies, what was the role of epistemic power and how influential can that be?
Okay, so here we are looking at different privileges. How So if you look at the different sources of power that I talked about, so the control over knowledge, resources, skills, and then by virtue of one's position. So that's a privilege. Okay. Now, you in power analysis or even in policy analysis, you want to know by virtue, because some people may occupy positions, have privileges, but may not necessarily use it in a policy process. And so having power is good, but you should be willing to exercise that power to make influence. So you may have privileges, different forms of power. If you have no interest in the issue at hand, you are not going to exercise your power. So that's one way to look at it. You can be influential, but not have interest. In policy analysis, one thing that's also very useful to do is a stakeholder analysis, where in the stakeholder analysis, you try to look at the power, their interest, and so the interest to the issue that you are investigating. They may have power, but not be interested, or it doesn't affect them in any way, or it affects them marginally. So because of that, they are not interested. Okay. Some could be influential, but other people are influencing them. The fifth source of power, the people who have access to the powerful people. So a director can be very influential, but married to a midwife. And the midwife is dictating how maternal policies should be made. Okay, so these are all things that you want to try to unpack in your study. I hope this helps. Okay. Simon, you are muted.
Sorry, I forgot about that. I see that Andiswa has clarified her question, and she was wanting to ask you what you think are the kinds of skills that a researcher needs to be involved in exploring or researching these kinds of policy processes. You've talked a little bit about that, but it'd be great if you could elaborate.
Okay, so I mean, usually this is purely qualitative. You are doing qualitative research. So you are doing a lot of interviewing, a lot of observation to observe what is going on. So that's a skill you need to build, how to talk to people, how to interview. And it can be very frustrating sometimes. I mean, you can book interviews severally. Policymakers are very busy. So you can book interviews severally, but you should still have the patience and when you meet them, so how to interact is a skill that we need to build. And also in observing. And when we observe, we have to note what we observe. Because even in decision-making arenas, the people who sit around the table and the people who sit outside, it tells a lot. When you go for a meeting and there's a round table and there's another one, those sitting around and those outside will tell you something. Is it that they are the people making the decision, or they are just looking on, or they are not supposed to be here? And then you probe further. So these are the main thing I'll say, the skills to interview, the skills to observe and document what one observes. I hope that helps.
Thanks. And I see somebody said yes, I did. And Trudy was asking your view on how one would assess or research power dynamics in these decision-making processes in a way that wouldn't undermine people's trust in you as a researcher, or sort of make decision makers feel uncomfortable, though I wonder whether that's possible, but in these kinds of arenas. But yes, do you have any thoughts on that?
Yes, the first most important thing, let them know why you are there. It's not journalism, this is research. So if you go and you have to go through the right channel. So you are collecting information, decision-making information from a facility, a health facility, you have to go through the channels. Do you have to go to the director with a letter? The director will minute, and then the people you are going to meet are aware that you have to be there. And this is what you are going to do. You are going to observe them. You are going to interview them. When they are not fully aware why you are there, then from the beginning, there's mistrust. And when there's mistrust, it doesn't go very well for qualitative research. So it's important they know why you are there. You build the trust from the beginning. And trust, is difficult to maintain. So constantly update them, what you are finding, be having conversations with them. And then with time, they open up and they can tell you a bit more. When you are done, you have to feedback. You have to validate. Some of these things may be very sensitive. So you have to validate your findings with them. Then they trust you. You can always go back to them for different research.
Thanks. Tamara, you want to come in with another point?
Well, yeah, it's almost the flip side of Trudy's question, which is, Augustina, in your experience, having, done these policy analyses, done this qualitative work, listening to people intently, and without, with trying to, like you've just described, being very clear on your role, that you're there as a researcher, you've gone via the right channels. Do you find that in any way changed your relationship or your understanding, or improved things, rather than creating distrust, created trust in other interactions after this work was done? Thanks.
Thank you. So this has set me thinking. So I think what it does as an insider, so for some research that I have presented here, I was within the ministry, so I will consider myself as an insider. For me, that will be a benefit, but the flip side is you have to be reflective to know that your presence there, because you have worked there before, is not influencing the things they are telling you and the access you have. Okay. So to do that is to try and triangulate, get information from different people, different sources, in a way to validate what is it that you are hearing and feeling because of being an insider. Now, as an outsider, I think this also applies. You have to be able to rely on varied information sources. So not just one venue, not just the ministry, not just the health directorates, not just the documents, but a mix of this in a way to validate. Sometimes people will say things because recall, they may not remember things, but you want to validate it from minutes from a meeting, for example. So I think it has its benefits and also some disadvantages. But again, using multiple data sources is quite useful in my experience.
Thank you.
Thank you too.
Thanks. I think we're essentially out of time for today, but I just wanted to end by thanking you again, Augustina, for this really interesting presentation. And I think it's particularly interesting given that you've been on both sides of the room, so to speak. You've worked in the ministry as a decision maker, or policy advisor, but also now, of course, working as an academic. And so you've seen these processes from both sides. So it was really interesting to hear your reflections on the way that power influences policy processes and how we might also explore that as researchers. So thanks once again. And as Tamara mentioned, the recording for this seminar will be sent to everyone who registered. Tamara, I don't know if you wanted to say anything about further seminars before we end for today.
Yes. Fantastic. So thanks, just to echo Simon, what an interesting session. Thank you so much. I wish we could talk more. The next session in a month from now will be feedback on the census 2022, the early findings, some of the misclassifications, some of the implausibility of the data in South Africa. So that's what's coming up next. But yeah, that's back to you, Simon, to wrap up. Thanks.
Yes, so that sounds very exciting, and looking forward to the next one. And I guess that will be advertised through the usual channels, so you'll hear about it there. And once again, thanks, Augustina, and thanks everyone for joining and for engaging with your questions. See you next time. Bye-bye for now.
Thank you for having me. Bye.
Thank you so much. And thank you, Simon.